talk about the revised National Tuberculosis Control Program, and we'll briefly discuss about the fixed dose combinations used in treatment of tuberculosis. India is the country with the highest TB burden. It accounts about 27.3%, where the global incidence is 10.4 million. For India alone, it's 2.8 million. These are the 6 countries that contribute for more than 60% of the new cases. That is, these include India, Indonesia, China, Nigeria, Pakistan, and South Africa. So, this is as per the Global Tuberculosis Report 2017. The estimated incidence is about 140 per lakh globally, where in India it is 211, again more. 33 deaths per lakh in India compared to 22 globally. MDR cases also more in India. In the same way, we have the HIV TB cases and the HIV TB deaths, which is reasonably lower in our country. So India contributes for about 25% of the all TB cases, MDR and RR cases and TB deaths. For management of TB in India, we have a benchmark for TB care. This consists of a set of 26 standards. These have 6 standards on diagnosis, 5 for treatment, 9 on public health, and 6 on social inclusion. The standard of TB care in India includes the following headings. That is the treatment for the new TB cases for the initial and continuation phase. In case if we have to extend the continuation phase for 3 to 6 months, like for special tuberculosis like bone and joint TB, spinal TB, and neurological involvement. Drug doses as per the weight bands, bioavailability ensured by every batch of FDC, dose frequency which has changed now to daily dosing, and the drug formulation in form of FDC. What is the objective of RNTCP? The first objective is to achieve a cure rate of at least 85% by using DOTS, and second is to augment the case finding activities through quality sputum microscopy to detect at least 70% of the estimated cases. There are 3 strategies. The first strategy is the DOT strategy, which has 5 components: political will and administrative commitment for management of TB, diagnosis by quality microscopy, adequate supply of chemotherapy, directly observed treatment, and systematic monitoring and accountability. The second strategy is the Stop TB strategy, which was undertaken in 2006, which comprises of pursuing quality DOTS, addressing the TB, HIV, and MDR cases, contributing to health system strengthening, engaging all care providers, empowering patients and communities, and enabling and promoting research on tuberculosis. In 2014, WHO approved the End TB strategy with a vision of world with zero death, disease, and suffering due to TB. The provision of care is through diagnostic algorithms and treatment guidelines. The diagnostic algorithm for pulmonary TB is with help of smear examination and chest X-ray. If smear examination is positive, with or without chest X-ray, it is considered as a case of microbiologically confirmed TB. If smear examination is negative with chest X-ray positive, or both negative, or if we have a high clinical suspicion, we directly go for CBNAT, that is cartridge-based nucleic acid amplification test, where if MTB is detected, we assess the rifampicin sensitivity. However, if MTB is not detected, we can consider alternative diagnosis, or we can consider as a clinically diagnosed TB. So what's new? There are newer tools for diagnosis. We have the high-risk population, we have new definitions, and new management. So new definition, what is presumptive pulmonary TB? Any person with symptom signs suggestive of TB, like cough for more than 2 weeks, fever for more than 2 weeks, significant weight loss, hemoptysis, and abnormality in chest radiograph is a presumptive pulmonary TB case. In the same way, the extrapulmonary TB, with those with signs like swelling of lymph node, pain and swelling in the joints, neck stiffness, disorientation, and or constitutional symptoms like weight loss, persistent fever for more than 2 weeks, or night sweats. In the same way, we have definition for presumptive pediatric TB cases, that is children with persistent fever or cough for more than 2 weeks with weight loss or no weight gain, or history of contact with infectious TB case. We have the presumptive drug resistance TB definition in the same way. Then we come to the diagnostic tools. These include the sputum microscopy, that includes the Zeal-Nelson staining, fluorescent staining. We have the culture techniques to solid culture media like LJ media, or automated liquid culture systems like Bactec or MJIT 960. We have the rapid molecular diagnostic techniques like line probe assay and nucleic acid amplification tests like CBNAT. The culture techniques, we have the conventional solid culture, we have the liquid cultures. WHO recommends the use of LED fluorescent microscopy. It allows the use of fluorescent microscopy. What is the advantage? That it is less expensive, toxic products are not broken down, and the sensitivity is sustaining. So as I said, WHO recommends the use of LED fluorescent microscopy over the conventional microscopy. We have the solid culture that gives results in 2 to 8 weeks for detection and 8 to 12 weeks for DST. Here the concern is biosafety. It's a robust task. However, when we use the liquid culture, uh, like semi-automated systems like Bactec 460, it gives a faster results. However, they are expensive and need a negative environment. Like if we use the MJIT 960 media that includes 7 ml of Middlebrook 7H9 broth with the oxygen sensitive dye at the bottom of the tube, which fluoresces on depletion of the growth of microorganism. It gives the positive results in 4 days and DST in 4 to 7 days. Capacity is about 8 to 10,000 annually, and we'll consider a test negative only after 42 days. In the same way, we have the molecular technique which are based on polymerase chain reaction. Uh, Advantage is mainly it is faster, results are available in 24 to 48 hours, and newer tests like CBNAT are even faster that give results in 60 to 90 minutes. These are some of the putative genes, the target genes that are used to detect resistance. Like for isoniazid, we have the CAT-G, INHA, and AHPC. For rifampicin, RPOB, pyrazinamide, PNCA, and so on. The same way we have genes for all the. Then we come to the line probe assay. It is mainly used for detection of resistance to various drugs by involving their target genes. Like for rifampicin, we have the RPO gene. The line probe assay is commercially available by two names, that is Inolipa and Genotype MTBDR plus assay. It is approved only for sputum smear positive cases. It has a sensitivity of more than 95% for RIF and 70 to 80% for isoniazid. Specificity is about 98%. However, for using these tools, we need a trained manpower. So, we need a skilled manpower for using these tools. We need automated formats. We need clean room for doing these, performing these tests. It takes about 8 hours to give the results. This is the cartridge-based nucleic acid amplification test. It is based on PCR technology. So as I said, the main advantage is early results. There's no biosafety cabinet need. It's a closed system, so risk of contamination is less, and it is more sensitive and specific for TB than the conventional test. This is the diagnostic algorithm for the extrapulmonary TB. As I said, when the sample is available, we usually take it to CBNAT. and then we detect for MTB resistance. And if sample is not available on the basis of clinical suspicion, we go it for alternate diagnosis, or we put it as a case of clinically diagnosed TB. So how the treatment has changed now? In the intensive phase, we have the isoniazid, rifampicin, pyrazinamide, and ethambutol, whereas we omit the pyrazinamide in the continuation phase. We have the daily dosing through fixed dose combinations, and we have the weight bands for giving the dose. So frequency is daily now. It's 4 weeks per month, that's 28 days, and in any case, the intensive phase is not extended. So this is the dose for daily regimen. So this is the dosing in the adults and the children for all the first line anti-tubercular drugs. Combination of the 3 FDC, that is HRE. So this is how the dosing is done. It is easy to remember also. Like we have the weight bands here: 25 to 39, 40 to 54, 55 to 69, and more than 70 kg. In the intensive phase, that is for 2 months, we'll be giving in this way: 2, 3, 4, and 5. That is 2 fixed dose combination, 2 tablets, 3 tablets, 4 and 5 tablets. In the same way, fixed dose combination 2, 3, 4, and 5. Injection streptomycin is given in these doses as 0.5, 0.7, and 1 gram. So rifampicin, this is for the pediatric age group, that is rifampicin 75 plus isoniazid 50 and pyrazinamide 150 mg. And these are present as also available as dispersible and flavored tablets. So this is the overview of doses for the pediatric TB. In the same way, we have the weight bands here on the left side. We have the number of fixed dose combination tablets to be taken in both the intensive and the continuation phase. Then role of pyridoxine. It is obviously given to prevent the neuropathy, especially in high risk groups like those who are alcoholics, malnourished people, or pregnant lactating women, patient with pre-existing conditions like chronic renal failure or diabetes, and while treating NTM. The newer drugs is bedaquiline. The class of drug is diarylquinolone. It targets the mycobacterial ATP synthesis, so it is bactericidal, and this is how it is used. It is mainly used for MDR and RR TB cases resistant to all fluoroquinolones or resistance to all second line injectables, or XDR TB cases with all fluoroquinolone and second line injectable resistance. Treatment failure of MDR TB cases, treatment failure of XDR TB cases. So this is these are the places where bedaquiline is used. How it is dosed: for the first 2 weeks, 400 mg is given daily. For the 3rd to 24th week, 200 mg is given 3 times per week with at least 48-hour gap between the doses. And from week 25th to end of the treatment, continues all other drugs as per the RNTCP guideline. So it is mainly given for 0 to 24 weeks. Patients should avoid taking milk products or heavy fatty meals because they will decrease the absorption of bedaquiline. At a fraction of cost and inconvenience to the patient, the anti-tubercular drugs are wrapped in envelopes which are printed with hidden numbers. When a patient dispenses a dose, they reveal the hidden toll-free number and they call up this number immediately. What is the benefit? Patients don't have to travel to report that they have taken drug, so there is more convenience. What is the benefit for field staffs? They are more focused and more efficient care can be done, and for program officers, that is doctors, it is easy to monitor and get the accurate reports. So this is how the dots flow. Patient at the ART center with symptoms of TB, sputum is taken, patient undergoes sputum, undergoes CBNAT, then CBNAT, patient is identified positive for TB, then fixed dose combination is given, patient dispenses the medicine and calls the toll free number, and it gets reflected on the 99 dots dashboard. So as I said, there is sustainable development goal targets and NTB target goals. The vision is to have India free of TB, and goal is universal access to quality TBM diagnosis and treatment for all TB patients in the country. So we have some goals for 2030 and 2035. As per the NTV strategy, the reduction in number of TB deaths has to be by 95%. As per SDG, it is 90. Reduction in TB incidence by 90% as per NTV and 80% as per SDG. In the same way, TB affected families facing catastrophe due to cost of treatment, it has to be reduced to 0%. We have the three pillars and the four principles for TB management as per the NTB strategy. Three pillars are integrated patient-centered TB care and prevention, bold policies and supportive system, and intensified research and innovation. And the four principles are government accountability, building strong coalition with the civil society and communities, protecting and promoting human rights and ethics, adapting of strategies and targets at country level, and collaborating it with the global policies. So that is all about RNTCP and a brief review about the treatment of tuberculosis in India. Thank you.